I'm Stefano Francione from Milano, Italy, working at the Claudio Monari Epilepsy Surgery Center, and I will try to summarize the workshop that we held at the beginning of the ILE International Congress 2011 in Rome about pediatric epilepsy surgery. The Claudio Monari workshop 2011, which was dedicated to pediatric epilepsy surgery at the beginning of the third millennium. This workshop was divided in two parts. The first one dealing with indication to surgery and non-invasive diagnostic procedures, and the second part dealing with invasive diagnostic procedure, surgical procedures, and results. In the first speaks, Professor Dalla Bernardina from Verona told us that indication for surgical treatment in children must be considered not only on the basis of drug resistance and seizure frequency and severity, but also on the basis of cognitive development and behavior. Particular attention, however, must be put on having a good knowledge about specific genetic entities to avoid unuseful surgery in cases like a patient with ring chromosome 20 or other genetic mutation. A very important tool, as stated by Dr. Ansolthausen from Vogteroid, Germany, is video G recording, and is important to state that whenever seizure persists with one or two antiepileptic drugs, a video G monitoring is the most powerful tool to acquire electroclinical information that helps for defining the epileptic syndrome and or for having a first assessment of the location of the epileptogenic region. With this information, as well stated by Dr. Lucia Fusco from Rome, helps in performing a high-quality MRI, which is mandatory for correct pre-surgical evaluation, and it must be performed and analyzed taking into account brain maturation and electroclinical features. As I said, the second part of the workshop was dedicated to the analysis of the utility of invasive procedures such as subdural recording, treated by Professor Luders from Cleveland, United States, and by stereo G, treated by Professor Kahn from Grenoble, France. Both said that invasive recordings are probably less frequently used in children than in adults, but they remain mandatory in many situations, especially extratemporal and MRI negative cases, in order to delineate the seizure onset zone and or to perform functional mapping, also giving the possibility to evaluate objectively the chances of seizure freedom after surgery. By the past, subdural electrodes were mostly utilized in children since they allow to cover a large part of the cortical surface and permit a precise functional mapping. As you can see in this part of the slide, where there is a reconstruction of a brain with the subdural grid implanted, in fact, the coverage of the surface of the brain is wide, and it could be reconstructed the function of a different part of the brain. In this sense, this yellow circle are the motor region. However, there are a number of potential epileptogenic brain regions that cannot be sampled by subdural electrode, such as, for instance, mesiotemporal region, insulan, and plano temporale, and therefore, stereo G recordings that have been proved safe and feasible in children as young as 3 years are increasingly utilized. And as you can appreciate in this part of the slide, in fact, the intracerebral depth electrodes can perfectly sample the cortical areas of the insula, the depth of the suicide, and also the intralesional tissue of whatever lesion we need to explore. After this, Dr. Giorgio Lorusso from our center in Milano took us about different surgical techniques, saying that a number of surgical procedures are available in children, from lesionectomies to tailored corticectomies, large multilobar resection, and even complete hemispherectomy or hemispherotomy. We have some example of this kind of surgical resection, such as this sublobar resection in this case, this frontal lobe complete resection in this case, this kind of occipitotemporal resection, till an hemispherectomy procedure or an hemispherotomy procedure like this one. The most important criteria for choosing one procedure rather than another is to carefully analyze individual anatomo-electroclinical correlation. Proceeding in this way, as Dr. Ingrid Tucson from Cleveland stated in the last talk of the workshop, excellent results can be obtained in terms of seizure freedom, even if cognitive improvement need to be better evaluated, especially in the so-called catastrophic epilepsies.